So I'm pleased to welcome you to the 2025 Dr. Frederick Dushay Distinguished Visiting Professor Lecture. The lecture is named for our longtime friend and ardent supporter of the Eye Institute, Fred Dushay, who unfortunately can't be with us today. But Fred has been a constant in the FEI resident clinic for over 25 years, and he has shepherded a stream of trainees, helping them learn the nuances of ophthalmology and patient care, and especially refraction throughout his career. And he has maintained the perspective of never letting technology or diagnosis come between the doctor and his patient. He entered the University of Rochester residency program after completing medical school at SUNY Upstate in Syracuse. And at that time, the ophthalmology department was a division of Strong Memorial Hospital's Department of Surgery, and he was one of 3 residents who covered Strong Memorial Hospital and Rochester General Hospital. But unlike most graduating residents, he didn't go straight into practice. Instead, he completed a fellowship in neuro-ophthalmology at Mass Eye and Ear under David Kogan. And in 1998, Fred joined the faculty at the University of Rochester Department of Ophthalmology to provide resident education. And since then, he's helped train more than 80 residents, many of whom went on to academic medicine. He continues to precept residents in the Urgent Eye Care Clinic to this day. He's a consummate physician, teacher, mentor, and friend. Thank you for supporting this lecture, Fred. It's my pleasure now to officially welcome you to the 2025 Frederick Dushay Lecture and introduce Dr. Lanie Ross. She is truly worthy of this honor as the Fred Dushay Distinguished Lecturer. As an educator, researcher, thought leader, and clinician, her work has profoundly shaped how we think about medicine, science, and society. She's the Dean's Professor and Inaugural Chair of the Department of Health and Humanities and Bioethics at the University of Rochester Medical Center, where she also directs the Paul M. Shive, MD, Center for Bioethics. A practicing pediatrician and philosopher, she brings a rare and powerful dual perspective to some of the most complex ethical challenges in modern healthcare. She received her medical training at the University of Pennsylvania and completed a pediatric residency at Children's Hospital Philadelphia and New York Presbyterian Morgan Stanley's Children's Hospital. She later earned a PhD in philosophy from Yale University. Dr. Ross has authored 5 books and over 225 peer-reviewed articles exploring the ethical dimensions of relationships in healthcare. Her scholarship spans pediatric ethics, genetic and genomic policy, organ transplantation, research ethics, and health equity. She's been recognized with numerous honors, including election to the National Academy of Medicine in 2023. In addition to her research, Dr. Ross has been a dedicated educator and mentor, shaping the next generation of clinicians and scholars in bioethics. She has served on editorial boards of leading journals such as the Journal of Pediatrics, the Journal of Clinical Ethics, Perspectives in Biology and Medicine, and the Journal of Empirical Research and Human Research Ethics. Today, Dr. Ross will guide us through the ethical landscape of emerging genetic technologies in ophthalmology, an area where the promise of innovation intersects with profound questions about consent, equity, and the future of patient care. Dr. Ross, welcome.
Thank you very much. I'm truly honored to be giving the Dushay Lecture. I do have disclosure, my spouse owns stock in GE Health Technologies in Bristol Myers. I won't be talking about anything in this discussion. So I have a PhD in philosophy, so I'm an absent-minded professor, and I'm gonna get on a bus today, and I have a blood sample of yours. I'm gonna say it's in a green top tube, and I have your chart. And I'm gonna leave one of those on the bus. And so what I want is for all of us to vote whether you want me to leave your blood sample or whether you want me to leave your chart. Remember, I teach undergraduates as well as medical students, so I'm willing to call on you. So please vote. So how many want me to leave your blood sample? They're labeled. So's your chart. How many want your blood sample? Okay, how many want your chart? So it's divided. Okay, well, we're gonna see how we vote at the end. My learning objectives today, thank you for voting, is to appreciate the ethical issues of genetic testing, and it's important for patient counseling, understand the ethical issues involved in gene therapy and gene therapy research and its implications for patients and families with heritable eye disorders, and then appreciate the diverse ways in which genetic information may impact patient decision-making. So I just love to start with some basic facts because I graduated medical school in 1986. We did not have a genetics course. The first gene that became relevant as a pediatrician was really the identification of the CF gene in 1989. So the number of genes in the human person, anyone want to scream out a number? How many genes do we have? Oh, we got more than two. Even the eye has more than two. Come on. 40,000, I hear. So in 1990, we thought there were 100,000 when we started the Human Genome Project. But by February 2001, when we created the draft, it was down to 30 to 40,000. When they came out with the almost complete draft in 2004, they thought it was somewhere between 20 to 25,000. And today we think there are about 20,000 protein coding genes. Now, there's probably another 10 to 20,000 genes in the non-coding area, what in my day was called the junk DNA. I love our hubris. But anyway, I want to compare us to the tomato because here's an article from 15 years ago which says that the tomato has 31,760 genes, which they thought was about 7,000 more genes than a human being. So either the tomato is more complicated than we are, or we're more than our genes, which is going to get back to the bus. So the difference, of course, between genetics and genomics is genetics is looking at one gene, one disease. Mendel only got it partially right because there are modifier genes, there's gene-gene environment interactions, and most disorders actually are multifactorial and involve more than one gene. But when we talk about genomics, we're talking about the whole genome. We're talking about 3 billion base pairs. And when we talk about the exome, we're just specifically looking at those probably around 20,000 protein-producing genes. With another probably, and I say probably because we really don't know exactly how many genes are involved in regulation. So I want to start with a couple of cases, just because that's how ethicists think. So my first case is Mr. and Mrs. D, who are the proud parents of Donald, a well-appearing 2-week-old boy. And during the first visit, you learn that Mr. D had retinoblastoma as a child and had his left eye enucleated, and he has 2100 vision in his other eye. Especially, as you all know better than I do, retinoblastoma, especially bilateral, is familial. And so they wanted to test the dad before pregnancy, and even while Mrs. D was pregnant, he refused. And they actually encouraged them to undergo prenatal testing, and they refused that as well. So back in the day, when I went to medical school, when we hadn't actually identified the RB gene, which comes in the early 1990s, anybody who had a family history like this would get frequent eye exams. And the big issue, of course, is at some point we start doing the eye exams under anesthesia. And although it's a debate in the pediatric literature how dangerous early anesthesia is in infants, we know that multiple doses of anesthesia, if you could avoid it, it would be good to avoid it. And so that was the old way. The new way is we're going to determine whether he's high risk, intermediate risk, low risk, or the general population. And that's going to influence how frequently we're going to do an eye check, if at all, and whether we're going to do it under anesthesia. So why might Mr. and Mrs. D refuse prenatal testing? And the answer here is it's not going to change their medical management. They're bringing this child to term. Why put the child or the mother at any risk? But there's a big difference between prenatal and neonatal. Now the baby's out, we can actually get a simple blood sample from the child. A blood sample is low risk, although it has important information. And so in pediatrics, we always talk about what's in the child's best interest. And given that if this child has a gene for retinoblastoma, we're going to want to do frequent eye exams. It's in his best interest to know whether he has the gene or not. Because if he doesn't have it, we don't have to put him through the anesthesia. In my day, they would go through anesthesia, they would go through exams until they were about 5, at which point the doc would say, good news, your child doesn't have retinoblastoma, or most likely doesn't have retinoblastoma. So the question is, what if they continue to refuse genetic testing? What should the doctors do? And so we have 3 choices. We can either, one, say, okay, parents have the right to make decisions for their children, so we're not going to force it, but we're going to want to see this child, and we're going to treat this child as a high-risk child, like we used to do. A second option is to go to the courts and get a mandate for the blood test. And the third is just to accept their refusal. I don't think anybody's going to just accept their refusal. And so one has to sort of balance what are the pros and cons, what are the costs, the risks of doing these eye exams. And I think most people, particularly most pediatricians, we would say, you know what, we're going to start with the frequent eye exams. But the great thing about pediatrics is we have a longitudinal relationship. We're going to spend time at every single appointment, the pediatrician as well as the ophthalmologist, talking to them about the benefit of getting that eye exam. And maybe after 4 months or maybe after 6 months, they're going to have developed trusting relationships and they're going to be willing to get the eye test, the genetic test. And therefore, we can then decide whether we need to continue the eye exams or not. But the real question comes, what are we going to do if they actually refuse getting eye exam? And here we may be talking that some would say that a 50% chance having a disease that can both risk eyesight but also can cause mortality, that might lead us to start thinking about getting the state involved in child protective services. So what I've just said is that we actually think that getting the genetic test is best, but most of us would tolerate if they were coming in frequently for all of these eye exams as recommended by the protocol. So the ethics that we're dealing with is we're dealing with parental autonomy, parents' right to raise their child as they see fit, versus beneficence or what's in the child's best interest. And we actually give really wide deference to parental autonomy, in part because parents make lots of decisions every day for their child. And we, both the healthcare community and the state, really don't have the time, energy, or ability to sort of step in at every single decision. So while we aspire that parents should make the best interest, and we talk about that, we often accept what I'll call good enough. So that really where we draw the line, it's not when parents fail to act in their child's best interest, but when they reach some level of harm or abuse or neglect. So let's take all that we just learned in case 1 and take it to case 2. So I did a lot of ophthalmology learning in the past 6 months. So Mr. and Mrs. P are the proud parents of Phyllis. She's a well-appearing 6-week-old girl. She has a brother, Peter, who's age 20, who was diagnosed with Stargardt syndrome at age 18, and the parents want genetic testing of Phyllis. So from what I understand, it's the most common juvenile macular dystrophy, but the presentation that the clinical features and progression vary widely from patient to patient, and the progression of vision loss doesn't correlate with fundus appearance. It's usually autosomal recessive, so she does have a 25% chance of having this disease, and the most common one caused by ABCD4 gene. But the limit is that genotype doesn't equal phenotype, and there are many variants of unknown significance, and this will be even more pronounced in populations that are not of European ancestry. So this raises a lot of ethical questions about who to test and when to test. Clearly, we want to be following this child, but the question is do we want to be testing, given that right now her eye exam is totally normal? So this was an article from 2024 looking at 460 patients with the ABCA4 associated gene, and it basically says it's likely that most patients in any cohort will harbor a unique genotype. The latter observations taken together suggest that patients' clinical findings in most cases will be more useful for predicting their clinical course than their genotype. So they're arguing, examine these children. We don't need to always be doing genetic testing. So my question is, how many are willing to test Phyllis as an infant with a normal eye exam? Most of you are not. All right. But would you encourage testing her as an infant? That sounds like no, she's not really going to test it. What if they really keep demanding it? How many are going to just say at some point, they're going to need to know at some point anyway? Anybody? Am I getting any increase? I got one more increase. Not many. Interesting. Okay, well, so ethics would also counsel against, but recommend annual eye evaluations or as frequently as you all tell me that the child needs it. But if the parents insist upon genetic testing, it's probably permissible ethically, since it does present in childhood. It says that the parents still have the right to make decisions about disorders that present in childhood. It would be more interesting if we were talking about a disorder that doesn't present until adulthood. For example, if we weren't ophthalmologists, but we were talking about Lynch syndrome or breast cancer, which only presents in adulthood, there the ethicists would say that really is a decision that belongs to the child. But if this gene can present, if the parents pushed hard enough, most ethicists would sort of begrudgingly say, well, it's within the parents, it's within that good enough, it doesn't reach abuse or neglect. Of course, we might not write the letter to get the insurance company to pay, which may be one way of discouraging them from getting testing. But of course, that also leads to different issues like disparities. So I want to move then from genetic testing to sequencing and sort of show you why having an ethicist around sometimes is actually useful. But here's a case study. So this is whole genome sequencing. So we did the whole genome sequencing. It's actually the first reported whole genome sequencing in the literature ever, came out in 2008. And I'm going to circle 2 that are homozygous, and I'm going to note that it has an asterisk which says that the coverage at these SNPs is less than 5, which means that the way that we did it under Sanger's sequencing, we don't have a lot of confidence that these are actually homozygous. But regardless, these are benign phenotypes, so we don't really care. But then we have 2 other homozygous, Cockayne syndrome and Usher syndrome 1B. And here we're going to note that the SNP coverage is greater than 5. And so both would produce severe phenotypes if they were truly homozygous. And again, really, even back in 2008, we would have liked coverage of at least 20 or 25 times. So it's not like we print out all 3 billion base pairs. We keep getting sections and we keep overlapping them. And so when I say more than 5, it means we have 5 times that area of the human genome. So Cockayne syndrome, failure to thrive, microcephaly, and cognitive disability. Usher syndrome type 1B is going to lead to deafness and progressive vision loss. So I want us just to take a second and think, how would you counsel if this was about a fetus? How would you counsel a pregnant couple? How would you counsel parents of a toddler? And I want you to imagine what this individual is like or would be like at age 40 years. This is the genome of James Watson, the Nobel laureate. Now, to be fair, it was using older technology, Sanger technology, and we're now using next-gen sequencing, and we get much greater coverage. However, he isn't the only adult, healthy adult, who has been screened for mutations that would present in childhood who didn't present. So this was a study by Rong Chen, and they screened for 874 genes believed to cause 584 distinct severe Mendelian childhood disorders. And they looked for healthy adults. So they got genomes from around, and they collected 589,000 genomes. And they went to look. And what they found was 13 of these individuals had genes that would have had them suspected to have cystic fibrosis, Smith-Lemli-Opitz, some pretty serious conditions. And yet these were labeled healthy adults over the age of 50. And they noted that they were unable to contact any of these to find out maybe it just wasn't expressive in them. Maybe it passed on to their children or grandchildren. They had no idea. But they noted that the original informed consent did not allow recontact. So we just know that there are people out there who have childhood onset conditions and do just fine. I don't know if Watson ever got his genome reanalyzed. It was actually got very controversial, because the only area he didn't want on the web was the area around ApoE4, which is associated with Alzheimer's disease. But they blocked out a period, and even AI at that time, enough machine learning, some people were able to figure out exactly how many repeats he had and whether he had the gene, and he was really unhappy about that. So what are the risks of sequencing healthy people? Well, first, the American College of Medical Genetics has put out a recommendation that anytime you do sequencing, that you should look for what they call high-risk alleles. Now, that was how they felt in 2013. They've backed off a little bit. They now actually say that adults can refuse to get this information because what's high-risk alleles were in high-risk populations, so that they were looking for BRCA in families with a lot of breast cancer. It turns out there are many more people who have variants of unknown significance in some of the BRCA alleles. We don't know what it means, particularly without a family history. And that becomes even more important when you look at individuals from non-European ancestry, where we have even fewer samples to figure out how significant those variants are. The variants of unknown significance, one of the things people will always talk about going and doing direct-to-consumer testing, and what they will find is you go to 5 different companies and you get 6 different readings, that some say it's a high-risk variant, some say it's a low risk, some say it's not even a variant. And so it leads to this need to get reviewed over time and then to get reclassified. And that's part of the reason that 23andMe was a bad business model, because they got one sample and people could just kept getting it reclassified and reclassified rather than submitting new samples. And finally, again, all of these variants of unknown significance are going to be even more unknowns in individuals from non-European ancestry. So we talk about, when we talk about the sequencing and looking at all these variants, we worry about overdiagnosing, leading to unnecessary medical follow-up and the following resulting iatrogenic harms. We're concerned about potential discrimination. Although GINA was passed, which is the Genetic Information Non-Discrimination Act, which means that you can't be discriminated against from getting health insurance, GINA does not cover you from life insurance or disability insurance. There's concerns about the anxiety and distress from false positives, and sometimes we don't even have an ability to actually know whether it really is a false positive, or whether it's just a low penetrance, or whether it's going to present later on. There's then false reassurance from false negatives, and of course, all of these variants of unknown significance. So here was a recent paper looking at next generation sequencing, applying it only to inherited retinal diseases. And it points out that it represents a collection of phenotypically and genetically diverse conditions. And they actually do a really nice job in the paper talking about all of the genetic uncertainty. They say, even when we find the variant, we may not understand modifier genes, so that we might not actually know whether this is going to present, how severe it's going to be. Then they talk about, even when we talk about X-linked, the random X inactivation for X-linked conditions impacts penetrance and severity. They explain that cis or trans elements may influence severity, that incomplete penetrance means that higher than expected allele frequency for pathogenic variants located in the genes of healthy individuals in genome AD that they've already been able to identify. And basically, they came down to there's still much we do not know, and came down not recommending next generation sequencing for inherited retinal diseases. Another recent article just looked at the ethnic disparity in using next generation sequencing for inherited retinal diseases. And this one specifically looked at how you had a lot more inconclusive diagnosis rate was present in Asian populations. And I'm sure and it was done in China, in Taiwan, I'm sure the same could be said for populations here with African ancestry or Hispanic heritage. So one of the real issues right now at this early stage of the expansion of genome sequencing is that the vast majority have been done of those from European ancestry. And we really, in order to be able to help the broader population, we are going to need to figure out a way of getting people to trust us to provide samples so that we can understand the significance of these genes in different populations. I'm going to leave from diagnostics. I want to hit therapy. I promised I was going to go from diagnosis to therapy. Here we have in vivo, where we're actually going to deliver it to the patient using a viral or a non-viral delivery vehicle, versus ex vivo, where we're going to do all of our gene therapy machinations in a test tube, and then we're going to re-put the induced modified cells back into the patient. Now, gene transfer trials have risks, and Dr. Alex Levin started talking about the Jesse Gelsinger case. So this was an 18-year-old who actually had a partial OTC deficiency, which means he was actually doing quite well with some mild dietary restrictions, in contrast to the full-blown OTC, which is often fatal in infancy. But CHOP did not get permission to do any of their gene transfers initially in the young children. And so they were looking for adults who had these mild presentations to do a phase 1, which we all know is supposed to be about safety and not about curing. And so Jesse, very appreciative of all the care he had gotten, had decided he actually flew up on his 18th birthday to become part of this study. On September 13th, Jesse was injected with an AAV vector carrying a corrected gene to test its safety in a gene transfer trial at the University of Pennsylvania. I will acknowledge that it's my alma mater for medical school. He died 4 days later, having suffered a massive immune response triggered by the viral vector, leading to multiple organ failure and brain death. His parents were very worried that this was going to lead to sort of the end of gene therapy, and really went in front of Congress, went in front of the FDA, saying that Jesse understood these risks. They were totally in support of it, until details started to come out. And some of the details that came out were some of the ethical lapses. First, the approved protocol talked about injecting the gene therapy into his bloodstream. In actuality, the researchers injected it right into his liver. The consent form had omissions Originally, it was supposed to say that several monkeys had died in some of these studies. That got left out. They didn't mention the conflict of interest, which seems, the numbers seem small in today's day and age, but back then, Dr. Wilson looked like he would have, if had this been successful, was looking at $9 to $10 million, and Penn was also looking to earn about that much as well. The inclusion and exclusion criteria were ignored. He had a blood test the night before. He had gone out to eat with friends and had a burger, a high amount of protein, and his labs were abnormal, and they still let him undergo the procedure the next morning. And it also was the case that this was the time when we had something called the RAC, the Recombinant Advisory DNA Commission, where you were supposed to report all of your adverse events that occurred from any gene transfer trial, and none of the adverse events in the two individuals who had come before him had been reported. Now, I have to say, Penn was not alone with this. When they realized what was happening with gene transfer trials, they actually had sort of a sanctuary week where you could report any of your gene transfer adverse events, and thousands of reports came in. So it hadn't been really a practice of really reporting it to the RAC, even though everyone who was doing gene therapy at that time was supposed to report it to the RAC. And so this put a damper on the whole field for over a decade in the United States. So we have Jesse in 1999, but of course we know that about 10 years later, we start seeing some real progress. And of course, the passage of Luxturna in 2017 as to treat LCA, which was really cool. And that by 2023, there were over 1,000 active trials. Dr. Levin pointed out that now there's been over 2,000 active trials, over 30 for ocular disease, and it's hoped for hundreds of millions of individuals. In 2025, these are already some of the approved cell and gene therapy products. So we really are moving quite quickly in the field. So although Leber's has been linked to mutations in 20 different genes, again, as Dr. Levin pointed out, they're really the most common are in the 4 genes, and they account for about 70 to 80% of the cases of retinitis pigmentosa. So the current therapy, Luxturna, was approved in 2017, was only for this one specific gene, and it uses an AAV2 viral vector. In September 24th, at Senna Therapeutics is testing for another one of these 4 rare diseases. It's also using an AAV virus, this time an AAV5 vector. And the reason it's important, once you use an adenoviral vector, you can only use it once, because after that you develop immune responses to it. So when you say, once you participate in one of these, you don't get to participate in another, which is why some of the mRNA vaccines that Dr. Levin was starting to talk about, or the nanoparticles, as I'll talk about later, is actually quite important. And so a Pennsylvania-based Ocugen is also trying to tackling each variant, said that tackling each variant is going to take decades. And so they're trying to target one of the key regulators, so that by going upstream, that they could actually try to treat more individuals rather than trying to go for every single individual, since we have 3 billion base pairs. And that's going to be a lot of individualized therapies that we're going to need. And their first study began last year in Canada. So the advantages of gene therapy for the IRDs is it's a immune privileged site, although not 100% immune privilege. Due to the small size of the retina and the lack of cellular proliferation in adulthood, only small amounts of the vector are required to treat these diseases. We already have these surgical procedure techniques known and able to administer ocular gene therapy products. And easy real-time monitoring is really a real benefit of being able to use gene therapy for these diseases. But although the eye is immune privileged, as I mentioned already, some of the disadvantages that it is more vulnerable to adverse immune reactions than previously believed. We have the cost issue, and finally getting regulatory alignment on the endpoint, given that visual acuity is not an appropriate endpoint for many retinal diseases. So these are all things that we're going to have to think about as we think about what vectors or whether this is the right approach for it. So what are some of the challenges and risks of somatic gene therapy? I just want to contrast the eye versus the somatic gene therapy. So in June 2016, Juno had 5 deaths in a study for ALL when they were using gene therapy due to cerebral edema, right? So if the gene therapy can get into the brain, you can see things like that. Now, Chimera and Yescarta didn't recorded during their clinical trials, because in one sense, when we do a clinical trial, we really cherry pick who our participants are so that we get the cleanest results. And it's as we try to expand it beyond that we start seeing many more side effects than we were picked up in any of the trials. With SMA, again, didn't see many problems in the trials, and yet there have been 2 reported child deaths since Zolgensma has been approved for SMA therapy. And in 2025, Sarepta reported their first death after patient received the Duchenne muscular dystrophy gene therapy, Elevidys. So, and in that study, efficacy studies have also been weak. So we're making progress in the somatic, probably slower than we're making in the eye, again, because of the advantages that the eye has. Here's a systematic review looking at AAV gene therapy vectors back in 2024. And their conclusion was it appears to be safe, but the surgical procedure required to deliver them is associated with some risk. The large variability in efficacy can be attributed to the small number of patients treated and the heterogeneity of the population and the variability in dosage, volume, and follow-up. So I think people are really starting to look at the questions of safety and efficacy. And again, it's not just the short term. We are going to have to think about what does it mean in the long term, and how long will these vectors do well. So those are the ways we've been traditionally doing it, but there's been a lot of excitement now about gene editing tool, where we literally go in and either we cut out part and we put in a new gene, or even more recently, we just literally correct one base pair. And there are multiple ones that have been tried, zinc finger nucleases, talons, but the one that we mostly talk about is CRISPR because it's the easiest to use. In some ways, too easy. There are people who do it yourself studies on YouTube. You can watch how to do it in your garage. Again, just like with the gene transfer, we have genome editing. You can either do it again in vivo or ex vivo. The first real big success with CRISPR was for sickle cell disease. Started in 2017 when CRISPR Therapeutics announced the submission of their clinical trial. They were going to do both thalassemia and sickle cell disease. Victoria Gray was the first person in the US to be enrolled in this trial. It had been going on in Europe, mostly for thalassemia. And within a year, she was free of vaso-occlusive crises, and she's become a big advocate, and she's still doing quite well. Here's a picture of her 6 months after she had her therapy. And in December of 2023, it's now been approved to treat patients with sickle cell disease. One of the biggest obstacles has been the cost, that it hasn't been used as much as people had hoped it would be used for. The first in vivo trial using CRISPR for ophthalmology was the Editas study with their first patient in the landmark phase 1/2 clinical trial of CRISPR medicine AGN 151587 for the treatment of labors. And back in 2020, when they announced it, they also announced that they were actually they expressed some cautious optimism, and yet by owing to circumstances unrelated to the study, the sponsor paused enrollment after a dozen or so participants. And that was in 2020. It takes till 2024 when they get published in the New England Journal so we could see what the issues were. There had been 14 participants had been treated in the study, 12 adults, all had been non-Hispanic white, with 1/3 being male. There had been no ocular serious adverse events related to the study treatment or dose-limiting toxic effects occurring, but there were 22 ocular events related to the study treatment, and most notably being visual impairment in 2 of the participants. And so they just put a pause on it, and not clear when the next study will start up. But last week, there was a real big excitement across the country. So this is a non-ophthalmologic success story. This was the world's first patient treated with personalized CRISPR gene editing in vivo. And this happened to CHOP. It was this little child, KJ, who was born with CPS1 deficiency, so missing an enzyme, and so leading to ammonia accumulating in the blood, which is toxic to the brain. And so this child was going to be put on a protein-limiting diet, and he was going to be given some medication to help metabolize the protein. And the plan was, the New England Journal article, which comes out, is incredible. The plan was They're literally going to do an animal model, then they're going to make it a human model. They're going to get FDA approval for a first inpatient, and it takes about 7 months for them to go from literally identifying the one base pair that's wrong in this child to being able to inject it into him. Really cool. But during those 5 to 7 months, he's at risk for hyperammonemia if he gets a cold or if his diet is not restricted. Now, it's really easy to restrict an infant's diet, right? We just give them special formula. So that's not going to be the problem, but catching colds and things of that sort. Now, one of the things is that the treatment they're going to do is going to be a personalized nanoparticle hepatic base editing therapy, which is really great because they can give a small dose that has never been tried before. And if he tolerates that and it's safe, then they can give a larger dose. And actually, at the time of the New England report, he'd already gotten 3 doses. He was able to liberalize to some extent the amount of protein in the milk products he was being given, but he was still taking medicine to be able to help with the digesting of the ammonia. They haven't been able to do a liver biopsy because they're too scared to, and appropriately so on this baby. So clearly we're going to need longer follow-up. So what's the ethics issue? I tried to say it to the NPR, but they didn't capture it. The big ethics issue was that the alternative for KJ was proven liver transplant. Now, liver transplant has its complications. You're on immunosuppression for the rest of your life. I get it. But CHOP's argument was that that you had to wait until he was over 10 kilograms, and during that time he could develop hyperammonemia. But the fact is that there are not many, but there are several centers around the country that will do it in kids as small as 4 kilograms. And they have the 2 options. One is the left lateral lobe segment from the parent, which is actually pretty easy and pretty low risk, similar to sort of a kidney transplant, and even maybe less risky because the liver regenerates. The other option is to get on the deceased donor wait list. They stated that he was on the list, but we're not actually told if the parents were counseled about being a living donor or whether he was actually active on the list. And so the real interesting ethics question for me is, how do you consent parents for an experimental therapy if a good, not perfect therapy exists? And again, in Dr. Levin's talk, he started saying, well, it's really hard to get further advances in corneal eye drops if you already have corneal transplant. In a sense, that is the same problem here. And I, as an ethicist, well, I'm celebrating how well this child is doing. I'd like to really know that the parents really made an informed decision and realized that they had the option of liver transplant. So the ethicists worry about it. So is it ethically better? Let's say they actually got a good informed consent. Is it ethically better that they chose to risk waiting the 7 months? Is it better if they have an alternative, or if it's better if they don't have an alternative? Francis Moore from MGH back in the 70s, 80s, one of the leaders in organ transplant, felt that he was very nervous if we gave options to parents when there was no alternative. He said desperate parents make desperate decisions, and desperate parents lead doctors to make desperate procedures that are offered. But with the eye, we could say, well, it's not life therapy, it's more of a quality of life. So is it ethically better to be trying in the eye rather than in the liver? Or does it become ethically impermissible because it's not life-saving? Now we have to think about some of the off-target CRISPR changes, which is something that, again, has both short-term and long-term significance, and we really don't know. And so one of the real questions is, how do we consent these families? And I really hope that CHOP really engaged with a multidisciplinary team to talk with this family about their other options and the potential long-term effects that we really don't know. It's the unknown unknowns with giving this treatment to this child who's probably going to need more than one more transfer of the gene, the CRISPR-treated nanoparticles. So what can go wrong with CRISPR? Well, the treatment may not cure the disease, or worse, it may not cure the disease and may make the patient worse off, as it may cause other problems. Or even if it cures the disease, it may leave the patient worse off by creating new problems due to the off-target or gene-gene interactions. So let me end by saying genetic and genomic testing is increasing in utility. There's still much we don't understand, and they raise a lot of ethical issues about when to test and whom to test. The lack of diversity in research participants will cause downstream disparities. that gene-targeted therapies are expanding one mutation at a time, and unless we figure out how to treat upstream, it's going to be decades before we can successfully treat all the conditions that would benefit from gene-based therapies. So I'm going to go back to the bus before I end. How many want me to leave the blood sample on the bus? How many want me to leave the chart? Wow, we still have a few leaving the chart. Chart gives a lot of information. It also gives a lot of information about your insurance, your social security number, and your family health history, often your parents' names, as well as the fact is that a lot of your genetics are only susceptibilities, and your chart actually tells us what your health is. So I think actually for the time being, my phenotype is actually much more informative than my genotype. But I'm going to try to take both the blood tubes and the medical chart off the bus. Thank you very much.
Absolutely fabulous. We have time for questions.
The world of ethics, we used to think it was pretty stagnant. You know, there's beneficence and all these principles, that was it. But the world is changing. And when I think about pre-symptomatic testing, it's different. It used to be, well, there's no treatment until you're an adult. There's not going to happen. Now there's treatment. Treatment's on the horizon. How do we counsel families differently in this age? And number two question is, in this age of medical industry running these trials, we just had a trial here of gene therapy in which the company just decided to sell. So the patients were dosed, the patients have the gene therapy in their body, and the company says, goodbye, you're on your own. So what do we do in the real world, making ethical decisions when things are changing, treatments are coming, and number two, when the companies have control and can just walk out the door?
Yeah. Two, really, I like that we start with some hardball.
Welcome to ophthalmology.
So the pre-symptomatic, so one of the things is we have to figure out how, so we now have open notes and patients have access to their charts, but we're going to really have to figure out a way that we're going to be able to, in real time, be able to get back to people and make sure that charts are following people. It was why Google attempted to have Google Health and things of that sort, because what we really need is not to test everyone at birth or at 6 weeks or at anything, but to be able to go back to people who come from families that are at risk as therapies are being developed or as even preventions are being developed, and to be able to engage them. So I think one of the things this is going to require is a much more coherent healthcare system. How's that for a great request in 2025? The role of industry is also really important. This goes back to the Bayh-Dole Act. So this is 1980. There's been huge financial conflicts of interest, and we're not going to go back. And so we're going to have to figure out how we're going to work collaboratively. Your technology is going to be a disruptor. I think we're going to need more disruption so that we can work in parallel and make it that that we're all really working for helping the patients and not just for the stock market price tag.
I have a question. Thank you for a really interesting talk. So I'm a microbiologist, and I spent a lot of time doing whole genome sequencing of bacteria. And you made a point early on, I think, particularly as it relates to Stargardt's, just because you have a particular gene or a particular mutation, at least in my world, it means really nothing in some ways. We don't know if it's actually expressed, is it relevant for infection, that sort of thing. So I guess my question / comment is, how does the field of genetic testing kind of approach that? Because it's so complicated, right? Just because you have a mutation, we have no idea, the structure of the chromatin and how the histones are interacting and how the regulators and these really complex regulatory networks are working. So I guess when you counsel patients and we see these mutations, figuring out what is actually meaningful and what are we trying to treat? Just because you fix a mutation doesn't mean you fix the disease, I guess. No,
yeah. Those are really, really great points. So that was the whole point with the Stargardt, is that the feeling from the expert consensus panel is that let's get the phenotype first, because we won't know what to do even if we found a variant in the genotype. because it may not express, or it may express years or decades forward. But to the extent that there is a movement to do a lot more genomic sequencing, we are going to have to figure out how genomic sequencing can stay with an individual, and that people can go back and have relooks and be able to understand. So you're also pointing out that it's not just the genomics, it's also the epigenetics, and that's going to change over time. So even if my genome is static, the epigenetics isn't. And so the methylation and the histones and all of that is going to be really important. So the question is, are we even going to bother to store it? Or since doing genome sequencing, which was $3 billion in 1990 and took 20 years, is now less than $1,000 and takes less than 24 hours. Is it even worth it? Or are we just going to re-sequence people multiple times, particularly people who come with families from Mendelian conditions? And the fact is, although every Mendelian condition is rare, it's about 7% of the population that has at least one Mendelian condition that may be amenable to some sort of treatment or prevention in the future. So your question is right on.
I was just thinking too, the combination of traditional genomic sequencing with some transcriptomics. I mean, even with the kind of boom of single cell RNA-seq, there's so many ways to look at what is relevant in a particular cell type in a particular organ. So maybe there's some way to combine those and to make it more clinically relevant.
I'm going to turn that back to you, the microbiologist. I have the PhD in philosophy. Don't go there.
Hi, thanks for that talk. Rob Feckner from Syracuse. Now that you've dealt with all the easy ethical questions, could you comment a bit? I've been reading about the edits to the germ cell lines, the heritable gene editing. Where
the germ cell?
Yeah, where is the thinking now about rewriting the genetic code?
Yeah, if I had 10 more minutes, I would have covered it. So we all might remember back in like 2020 when Dr. He from China actually did some germline testing. There'd been a moratorium up until then, and he actually violated the moratorium, and he did so in quite a dangerous way. I think that there is still belief that until we understand enough of what we're doing in somatic cells, we shouldn't go near the germline. It's going to get much more interesting as we start talking about these single base pairs, right? Because it's a lot easier to fix, a one cell organism than it is when you have 3 billion cells in your body. But I don't think until we understand a lot more about off target and all of the other side effects in somatic that anybody should be touching the germline.